we're carrying on with the special circumstances for babies and how to monitor babies in different circumstances. We talked in the beginning, or in the previous sessions, we talked about meconium, we talked about chorioamnionitis and sepsis. Yeah. Today we're going to be talking about preterm and growth restriction. Okay. So you guys, everybody knows that I love going back to the very basics. We're going to take it from the very, very basic, and we're going to start by preterm. Let's start by, what does preterm actually mean? What does the term a preterm baby mean? Less than 37 weeks, is that correct? I mean, it is on the screen, so please
Yes.
try and be interactive. But are all preterm babies the same? So if I'm saying a baby that's less than 26 weeks, is it the same as the less than 28, less than 32, less than 34? Okay, are they all the same? And the answer is obviously no. Okay, and not just about the difference in gestational age, it's also the difference in why are they in labor. So why would a preterm baby be in labor?
Perhaps sepsis, if it's, especially if it's very early on.
Okay, anything else?
Or like an incompetent cervix, perhaps.
Okay, you're trying to describe spontaneous preterm labor, but many of the preterm labors are also actually induced. So we do them. It's not that they are going into labor on their own. Yes?
Yes.
As you correctly said, infection, SHROM, incompetent cervix, all of these can be a cause for a baby going spontaneously into labor. Okay. But again, infection or ruptured membranes with a bit of chorioamnionitis on top, that in itself can be an indication for us to induce, even if she's not going into labor on her own. Or there may be a medical condition for mom. That's why we're inducing early, because she can't tolerate pregnancy anymore. Or obviously a problem for baby, and the most common of which is growth restriction. We are going to leave growth restriction to be discussed a little bit separately, but these are the indications for preterm delivery, yes, being spontaneous or being induced. Okay, so we are trying to compare how we monitor and how the monitoring is going to be different when we're talking about a term baby and a preterm baby. Okay, so how is a preterm baby different from a term baby? And the answer is there's many, many differences. And it's not just about the baby itself. Everything within the pregnancy is slightly different. So let's start with the placenta. Is the baby's placenta different when it's preterm than when it's term?
I suppose if there's intrauterine growth restriction, the placenta might be the issue, and there it
So
might
remember,
be.
we're talking about a healthy preterm baby at the moment. We're not talking about a growth restriction baby.
I suppose it would be relying more on the placenta at an earlier stage.
It's relying on the placenta in all stages. Is the placenta different when it's preterm than when it's term? So is it smaller perhaps? Does it have less space within?
I'm going to say yeah.
Yeah. And obviously that also means it has less reserve within, because we always say that the placenta provides baby with oxygen when there's a contraction. When the uterus contracts, the placenta provides the baby with ongoing oxygen. So the baby doesn't feel any hypoxia at all, unless the contraction has gone so long that the placenta has run out of oxygen. So the placenta acts as a reservoir. If the baby's preterm, that reservoir is smaller. However, you can also say that the baby is also smaller, so metabolic needs are smaller. So in comparison, it may be pretty much the same, because it's a smaller baby, smaller placenta, equal. And this is, we're talking about a healthy baby. So well or normally grown placenta supplying this not very mature, but still well-grown baby. Does that make sense? So placenta is pretty much the same, as long as this baby is healthy and that this baby has been well grown and there is no infection. Okay. What about the cord? Can the cord be different? Is the cord any different when the baby's preterm than when the baby's term?
I assume it's also smaller.
So it's thinner, and it also has less jelly, so it's actually less protected. The fact that the cord is thinner and has less water and jelly means that it can more easily be compressed. Okay, so relatively of the same length, but it's thinner, hence more liable to compression. What about liquor?
I'm not
Andy,
sure necessarily different.
you need to try and help Sarah out.
Go down to DAU.
Proportional.
So liquor volume for a smaller baby actually has relatively more liquor than a term baby. The baby actually has more space, which means that it can be more vigorous in its movements. But that also means that if the baby has ruptured its membranes with a thinner cord, it has more space to lose. It actually gets the cord gets entangled or squashed more easily than a bigger term baby that has space in between its body. Does that make sense? But the liquor volume in itself is relatively actually more. So if the baby has intact membranes, the baby's cord is potentially less likely to get compressed than a bigger baby with less liquor volume in general. Now, does that make sense, Sarah?
Yes. Yeah.
Ahmed, I'm really sorry, but I've just got a call by DAU. I think I'm going to have to head down and see someone. But I'll catch up on the recording. Sorry.
That's fine, Angela. It's okay.
Okay,
Thank you. Okay. What about comparing the actual baby? So the baby overall, obviously a preterm baby is usually smaller. Yes.
Yep.
But that also means it may actually have less metabolic rate / metabolic needs. So it does not need as much as oxygen. Remember, oxygen requirement is based upon your body weight to a great extent. But also baby's blood volume is generally less because in general, baby has about 100 milliliters per kilogram. So if we have a smaller baby, we have less blood volume, meaning also less reserve, less oxygen carrying capacity. So everything has to be kept in mind when we're dealing with a preterm baby. Baby's protective mechanisms would be less mature. Remember, the protective mechanisms are mainly orchestrated by baby's brain and brain development. So if baby has a less developed sympathetic system, okay, it might not be able to redistribute its blood flow as effectively as a term baby. It can't produce as much adrenaline as well. Okay, if a baby has less mature parasympathetic system, it can't activate its protective mechanisms, so it can't slow down its heart rate as impressively as a term baby to protect itself against hypoxia. Similarly, its somatic system is not well developed, so it's not going to respond in a similar fashion, okay, because its somatic part of the brain is not well developed as yet, which is why we said at the very beginning, a very preterm baby, so less than 26 weeks, less than 24 weeks, is very different from a baby that's just about 36 or 35 weeks. They're very, very different, okay? And again, a very small baby has less glycogen stores, which means that even if it wants to go into anaerobic metabolism, it also can't compensate as much. So all of this we need to keep in mind when we are trying to figure out or to monitor the responses and fetal heart rate changes in a preterm baby. Let's talk more specifically about the CTG features, so the features on the monitoring. What do we think the baby's baseline is going to be like, oh, poor Sarah, you're left alone now. I can't grill you as much.
Is it likely to be higher as it's younger, and then it becomes slightly slower as it develops?
Yes, that's very good. So the baby's heart rate will start off being higher because the sympathetic develops first, okay, and then it should be gradually dropping. So the more preterm the baby is, obviously within range, the more preterm the baby is, the higher the baseline is going to be. But the similar issue is, remember, the sympathetic is not completely fully developed as yet. So if we're talking about a baby that's already starting from a high point in its baseline, if it's supposed to be raising its baseline further, there is only going to be a limited rise within, because the baby doesn't have the same ability to raise its baseline much further. If we're starting, say, from 160, the baby can push its baseline up to 170, maybe higher, but can the baby take it even higher? Is the sympathetic developed far enough to push it even higher than that? Okay, so we always have to keep that in mind. Similarly, if the baby becomes septic, can it raise its heart rate further? Even the heart muscles are not completely developed as yet. Okay. If baby's brain is not fully developed, what do you think the variability is going to be like? The baby's sympathetic parasympathetic interaction.
If it's got less parasympathetic, then will it have less variability?
Precisely. So the baby's variability doesn't fully mature, or we don't see it as we normally see it up until 32, 34 weeks. So a baby that's less than 32 weeks, the variability is obviously going to be less obvious, okay? And it's going to be within a smaller range. What do you think is going to be happening with the cycling, the sleep-wake pattern?
I'm assuming that it would also be less developed if it's less, generally less developed. It's less circadian rhythm, I'd assume.
Yeah. And we also notice that, or we also talk about cycling when we're looking at the change in variability, being slower or being smaller, and then increasing again, and then tailing off again. If the variability is generally reduced, cycling can be much more difficult to ascertain. Okay, we'll be relying more on the accelerative part of the trace rather than just the normal variability within. Having said that, accelerations themselves can be not fully developed up until 32 weeks. So less than 32 weeks, we accept an acceleration being 10 beats by 10 seconds. So a rise of 10 beats for 10 seconds. It's not the 15 by 15. The reason being is that the somatic system is not fully developed as yet. So the accelerations might not be as obvious. That makes monitoring is increasingly more difficult. Okay. What about decelerations?
Is it before 26 weeks? Is it decelerations are acceptable, or 24 weeks? And then after that point, then it's more concerning.
It all depends upon the reason. So we said that less than 20, the more premature the baby and the more premature the cord, the compressions can be more frequent. So the baby's cord can get squashed much more easily. And obviously, if the lady has ruptured her membranes, this baby's cord is going to get more squashed. If she's in labor and the baby's cord is getting compressed with every contraction, there are going to be decelerations, but they're not necessarily going to be as impressive. Okay, they don't have to be as deep because the baby doesn't have a fully mature parasympathetic system as yet. So they may still be recurrent, but they're not as fully developed. Okay. So all of this makes monitoring the preterm baby a little bit more difficult. You need to make sure that you understand what's supposed to be happening. We said that baby's baseline is a little bit higher, the responses are not very well developed, okay, and the cycling is iffy. We don't necessarily it's not the same as a term baby, okay, and the similar is it's not gonna respond the same way, whether it's preterm or term, as in how much it can raise the baseline. Remember, all of this we've been talking about the preterm baby. I'm not talking about an IUGR baby. I'm talking about a healthy preterm baby that just happened for its mom to go into labor because she's ruptured her membranes. Okay, not showing signs of infection, not showing any other signs. But we said that an IUGR baby or a growth restricted baby is something that we also have to keep in the back of our mind when we're talking about. So similar to preterm, growth restriction is an important thing to also keep in mind. Growth restriction is not the same as a small baby. Growth restriction means that this baby is pathologically unable to attain its growth potential. So a small baby is basically a baby that's less than the 10th centile from the general population. Most of those are just because small mom hence small baby, so it's constitutionally small. But it's a healthy baby, it's growing along the same centile. Yes, it may be associated with other risk factors in itself, or there's a higher population of those that are actually growth restricted, but most of those are actually healthy. This is different from the growth restricted baby that started at a certain centile, and as it kept on growing, it actually dropped its centile. That's a baby that's usually having problems with either placental or genetic problems, which is where we talk about something called symmetrical and asymmetrical. Symmetrical being that this baby is now symmetrically small, so baby's head and abdomen are losing the growth potential. Asymmetrically small means that baby's head is still growing, but baby's abdomen is actually getting thinner, which is more associated with the growth restriction. Okay, too complicated. Let's not go into too much detail of that. But in general, a growth restricted baby is the baby that we always talk about having chronic hypoxia. This is the baby that has, where the placenta has not been supplying this baby properly, hence it's not been providing baby with enough oxygen. Hence the baby has started off by losing its reserve. So the placenta reserve has dropped. As the restriction gets further, it's not been growing as well. And then it starts redistributing, meaning that it's releasing a bit more catecholamines, resulting in redistribution of blood from the non-essential organs. Does that make sense?
Yeah.
Okay. Obviously, if this baby is preterm on top of all of this, so the reduced reserve from being growth restricted with the reduced reserve from being preterm in itself, and potentially the more risk of cord compressions or the more risk of actual hypoxia just because this baby doesn't have enough blood volume or oxygen carrying capacity and glycogen stores, puts this baby more and more at risk, which is why the recommendation for that, the preterm IUGR babies, we tend to actually favor doing a cesarean section for them. Does that make sense?
Sorry, Ahmed, got cut off slightly mid speech, but I got the fact that if they are preterm
so if it's an IUGR baby that so if it's a preterm baby that already has little reserves and already has little stores, so little glycogen stores and less blood volume, hence less oxygen carrying capacity, if this preterm baby becomes growth restricted on top because of chronic hypoxia, that makes this baby more and more at risk because this reduced reserve puts baby a lot more at risk of hypoxic damage. That's why we do cesarean sections for most IUGR preterm babies.
Yeah, I got that. Thank you.
Okay. So that's basically preterm and IUGR in a small nutshell as I can make it. Okay.